Okay, thank you. Let's give it another minute or so while others join. And as people are joining, if you are one of our work group members, and here on behalf of your appointment as a working group member, would you please put your name and your affiliation into the chat, please, so we can keep track of attendance. If you wouldn't mind doing that as we're joining, just go ahead and put your name and affiliation into the chat if you are one of the assigned work group members, please. Okay, so I think we'll kick it off today. Thank you for joining us on our behavioral health delivery work group agenda. This is our HB 413 working group evaluating an integrated model for the TAM population. We appreciate your attendance and participation in the work that we're doing. I'm going to just go quickly through the agenda as we're opening up today. We're going to keep the conversation pretty tight to focus on, first of all, just going through the meeting minutes, but then really rolling into sort of what our vision is over the next several months with regard to work that we're doing, and then diving into some of the specific actions that are outlined in the legislation itself so that we can begin some work on that. So with that, I will first open the meeting by asking those of you who have had the opportunity to review the meeting minutes, if you would please, they were emailed out by Sharon, I think a couple days ago. And if you have a moment to just review the minutes from March 31st and go through those, I'd be happy to take a motion to approve those minutes or for any modifications to the minutes at any point.
I'll give a motion to approve.
Okay, thank you, Adam. Do we have a second? Okay, can I?
Second, this is Mark.
Okay, thank you, Dr. Greenwood. Okay, all in favor, if you are a committee member and would like to just designate your why does a failure to approve, you can indicate your denial, but others, if you could just raise your hand within the meeting to just designate your approval, I appreciate that. If there is any sort of opposition, you need to just vocalize that. Okay. That being said, we've got one vote of approval, assuming others on the call, if you are working group members, that there is no opposition to approving these minutes. So we'll move forward to our next agenda item. So what I'd like to present next is, and Sharon, you can take down, as others are just joining the call now. I'll first want to just walk through some items that are upcoming for us, and just to bring you in the loop of some things we want to bring back in a future meeting. So as many of you are aware, the department established some priorities around promoting models of integration across our Medicaid program, where we could have more models of integrated care for physical health, behavioral health, and including oral health care as well. And some of the work that we would like to engage in over the next several months is to begin conversations with stakeholders, including our ACO and PMHP provider partners, our ACO managed care partners, our provider partners as well, and others, in exploring what these next steps look like. One option that we will be engaging stakeholders in is to explore taking our adult expansion UMIC contracts, which now exist in our five counties, and expanding those contracts to our all of our ACO mandated counties. Today, we have about 65,000 individuals in the 5-county UMIC model. There are about 17,000 or so individuals today in these additional counties that we are thinking about, and we would like to engage in conversations with stakeholders and providers and those of you I mentioned about the expansion of the UMIC model. The second item that we would like to engage in conversations about are to further explore the feasibility of what we've been talking about here, but with a larger group outside of this working group, is moving TAM into the integrated UMIC model, and really talk through and get feedback from the community providers and other folks on that design. And with that, we intend to do this work over the next 3 months. And with that, we'd like it to bring back any feedback and recommendations to this committee for consideration at that time. Some of the things that we are thinking about, so I can set the context of this work, is the fact that we 3 years ago did submit to CMS an amendment to our 1115 waiver for a justice involved population. And since that time, as you know, CMS has released guidance. They've approved California's justice waiver. They have released formal guidance to states in the form of a state Medicaid director letter in April of this year for states to have a standard for justice-involved care. And as we're looking at beginning our conversations with CMS about this work, it's important for us to have a more integrated and uniform model for justice-involved individuals to move into that would achieve the goals of the justice-involved work that has been laid out by CMS. A couple important components that I just wanted to touch on with that are relevant to our TAM population and this working group. So first and foremost, we know that the TAM benefit was designed specifically for this population. While not all individuals who would be eligible through the justice work would be TAM, a good number of them would be. TAM certainly expands beyond this group. But as we look at the work of justice, some elements that CMS has defined that are a little bit different than our original application require states with their justice work to develop models that support high-intensity case management for individuals that are justice involved. This high-intensity case management occurs inside the carceral setting and includes either a continuous high-intensity case management upon release with either a same case manager or a warm handoff into the case manager at the provider, the external provider. This model also required and did propose but not mandate other elements. The high touch case management is a mandated element, but also supports health related social needs, which are as a benefit underneath the an 1115 waiver that supports 6 months, up to 6 months of housing, high intensity case management, and a food benefit as well. So there are numerous things that are wrapped up in the justice work that CMS has brought along aside the justice model that would help us support some of the work we're doing. And we are interested in exploring what that health-related social needs benefit might look like, not just for our justice population, but for those who would, for example, be high risk, like our TAM enrolled population. So much of this work kind of pulls in together as we look at our integrated model design that we have today and thinking about the work we're engaging in with CMS around our justice involved groups And then the necessity of care that we know we've been talking about with our TAMP population, some of which is justice involved, but some of which is not, and really building the right supports and proper care for that group. There are several things we intend to talk to CMS about and would like to bring you along into those discussions as we're doing that. Now, I know I've kind of laid out a lot, but I'm trying to kind of explain to you why we're now approaching our work in HB 413 through this lens, so that you're understanding sort of the framework of what we anticipate will be conversations with CMS in the coming weeks, even around justice work, as we look at their model of care they've laid out and how this affects the TAM population, and really does align very nicely with many of the things that have been called out in this meeting over the last year around the components of care that are so essential to help support the long-term outcomes for this group. So I wanted to bring everyone along with that, so you're aware of our broader work that's happening and then how it applies specifically to the TAM population. So with that, I'll stop and see if there are any specific questions before we move on. Emma.
Yeah, Jen, can you just clarify, because I think since the California model is broader than what we originally submitted, where legislative leadership is? I mean, because they're obviously going to play a role in determining how big this gets.
Certainly.
So,
there are like a few caveats that, so the California model isn't necessarily the model we're leaning towards and towards achieving that full robust model of care. But the SMD letter did outline a model that looks slightly more robust than the one we envisioned. And that's where we'd like to start with CMS. CMS is good with a ramp up. You know, if we start as a smaller version and extend, that could be a smaller version that we start with prisons and add on jails, or we start with, you know, but there are certain elements that are required that weren't envisioned as part of our original amendment. Beautifully, most of what we envisioned and was legislatively directed and was in the original amendment language. So the majority of what we did look at and submit to CMS did align very nicely. But there's, I think, 3 areas that we'd like to call out as important differences. One is this idea of chronic disease management within the population while they're in a carceral setting, being broad. It would encompass chronic physical health, behavioral health, and comprehensive SUD. Ours looked more specifically at opioid use disorder, and the requirement for CMS would require that we expand to incorporate the whole person with regard to physical health, behavioral health, and SUD services in that setting. We also, as I mentioned, are required to establish a robust case management service in that setting to really establish a good level of care there, so that the transitions into the community and those touch points are of higher success for the individual with regard to transitioning the plan. And so again, not that we couldn't add, and I don't know that we need extra legislation for either one of those components. It would just, our policy and the work as we envisioned it would be more aligned with what CMS has now defined in that area. Another piece that's a little bit different, and again, not in conflict with our current legislation, but is different, is that upon release, individuals are required to have a 30-day supply of their chronic medicines. So they have to have the medicines in hand. Another element that we did have as our defining feature was a 30-day enrollment prior to release. We can go back with our new, we could go back 90 days. So we could do 90 days pre-release, 60 days, or 30 days. So we'd like to contemplate that. So those are really the pieces that are a little bit different. We don't see barriers legislatively with implementing that model. We do see some changes if we were wanting to look at a 30 versus 60 versus 90 days pre-release like enrollment. That would have to be modified. And then the other concept would be more of the health-related social needs to build more of a robust service level of care, which could incorporate those pieces as wide as not saying that we're thinking this widely, but the HRSN model looks as widely as 6 months of housing where you're paying rent for up to 6 months for an individual, as well as even food support for that period of time. So there are nutritional supports that states are doing as well. We're looking at this. We're not sure. I think the HRSN benefit doesn't require that states adopt all of these. We could incorporate codes that look at high touch case management so that there's a different billing code for intensive case management that would be more aligned with the needs of this group versus non-intensive. And so we need to bring some new codes in to support that. And then, of course, we have been interested in some of the housing pieces. So those are some items we definitely would be needing some legislative support on, Emma. Okay. If there aren't additional questions on that piece now, know that there will be much coming. Much of our justice work today is bringing in our DHHS partners. So we're doing our internal planning. Would like by August to start engaging some of our external groups on this. So just know that that's coming, but we're meeting many times a week right now internally on these items, and will extend out in a matter of weeks. Yes, Joseph. Oh, my apologies. You're muted.
All right, can you hear me now?
We can.
So the you mentioned requiring a 30-day supply upon release. If your focus is on opioid clients as well, I mean, you're helping, the focus on everybody, right? But that's in one of the focus areas. We're really trying to move towards, you can't require, but encouraging our clients to get on the Sublocade shot. It's a much less abusive. It's something that they can't abuse it, rather than having Suboxone, Subutex. I don't know what that logistically looks like, how that's a possibility, but it's just a recommendation that I would love to see happen. If it's a possibility, it's something you guys can work on while you're in this process of building that out.
So what would happen is, and maybe I'm not understanding your correction exactly, but what would happen is that the Medicaid benefit, as it's designed outside of the carceral setting, would actually be eligible for individuals within the carceral setting. And the prisons and jails would be billing Medicaid for Medicaid eligible services, whether that's medications like Sublocade that could be delivered in that setting, as well as, DME also is another thing. We could be billed for other medical visits and things like that. Then it would be upon release that you transition out, and the person could have access to those things. But the full pharmacy benefit, as it's defined for us today, would be eligible to individuals in a carceral setting, is the intent.
Yeah, it just would be nice. Folks, struggle when they get out and they get on Subutex or Suboxone, whatever, and then it's just it can be oftentimes a spiral. It goes downhill. But if they're on Sublocade, they can't abuse the shot. They can't abuse it.
Right.
So it's just
No, it's great. It's one of the benefits of the long-acting injectables, right, for that purpose. So, yeah, thank you for bringing up that point.
Thanks. I realize it's sort of a minor point compared to the big picture stuff you're working on. But
no, it's an important point, though. Yeah, thank you.
Thanks.
Okay, so with that framework in mind and kind of just painting the vision of where we'd like our conversations to go, and some of the work that we know from a policy perspective will directly impact some of our TAM population, and just understanding sort of this framework around the type of care CMS has envisioned, at least for our justice involved population, and certainly one we would want to build, not just limited to justice, but certainly for a more broad group such as the TAM population. We would like to move into more of our content for today. With that, I'm going to pause quickly on one item to give you an update on something. The reason, I'm sorry I didn't have this on the agenda, but it is a policy update. So I'm going to hit a quick pause and just mention to you where our conversations with CMS are with regard to medical respite. We have been in conversations around a medical respite benefit, which is designed specifically for the TAM population for many months, as you know. We believe that we are in our last phases of discussion with them. We received a last list of questions, a list of questions from them just yesterday that we plan to discuss on Monday, and they are doing their final work with us on medical respite with the intent of getting that work approved very soon. And Brian, I just want to see a nod from you that you're concurring with this, that what CMS has told us, there are 3 different waivers that have been put together, requests. Medical respite is bundled with 2 fertility type requests that we have submitted, IVF and oncofertility. And with the approval of these, we will then begin our conversations about justice and begin the work on the justice. So they had promised to begin conversations with states in order of submission of their justice involved requests as soon as we get this one approved for medical respite. We will then engage in discussions with CMS on justice work. So I wanted to update you with regard to that additional benefit for our TAM population, which has been this longstanding work around medical respite, and we do believe we're finishing up on that. So with that, as soon as we do receive approval on that, we will begin our formal work to implement and design this policy. We will bring that to a future meeting for thorough discussion and vetting on that. So we'll make sure you're part of that conversation as well. And if time is needed to have a meeting before a quarter lapses, just because of timing and making sure you're in the loop on this work, we'll make sure that we have a meeting prior to that so we can have the discussions timely. Okay. Now with that, one of the items that we had talked about moving forward with now with the work of this group was to really go back to one of our action items that we were directed to do from the very start of our working group assembly. And that was legislatively, we were directed to look through 5 different items and come together to look at these items, which we have been discussing these items, but really develop some concrete recommendations from the committee to the department. And we want to walk into those today. I will share my screen here in just a moment, and I'm going to ask Brian to lead this part of the discussion. So Brian, if I just hand over to you, I will share my screen. And what we'd like now as we go through these elements is we really do need your feedback just to set the conversation properly. One of, I think the way that the language itself was crafted was really looking at how we were going to fit TAM into an integrated model. And the reference point of an integrated model that we've used through the department's notes has been our UMIC model. And so I want you to know that we've used that as our benchmark comparison throughout the different elements that we're going to walk through. So Brian, if you'd like to go ahead.
Yeah, happy to. Thanks, Jen. I'm also, okay, you got it presented. Okay, thanks. So this was as enacted by House Bill 413 and written into, it's now recodified as 26B3-138. This is really the first of the requirements and obligations of this working group to establish those specific and measurable metrics. So we, as a department, have put forward what we're hoping to be the starting point for the conversation. Some of these, as Jen mentioned, this has been part of a long-standing conversation, but as of yet, we've not said the working group in collaboration with the department has recommended these metrics, and the department has not adopted these metrics specifically through the collaboration process. So we want to advance that. And to that end, we're making these proposals for the 5 metrics laid out in statute. So first I'll go through, first item is compliance of managed care organizations in the state with federal Medicaid managed care requirements. So our proposal is that some of this is already in our managed care contracts, but we would define the metric that we require plans to comply with federal managed care requirements, and specifically attachment B of the UMIC contract outlines corrective action plans and the monitoring steps the department will take if a plan is placed on corrective action. So our metric is the existence of this requirement in the contracts and the corrective action plans that are required if it requires that a plan be placed on corrective action. So I'm now going to open it to the group for feedback on this proposal. Emma, go ahead.
Yeah, I as I was looking at this, I mean, isn't that also the responsibility of one of the responsibilities of the EQRO to make sure that plans are in compliance with federal requirements? So, I mean, it's being met both ways, not only contractually, but also federally by the requirement of having an EQRO monitor our compliance. So I think you can add something to this so that folks will feel comfortable that there are a couple things going on.
I do like that. So that is a potential addition that we could add in EQRO oversight, the existence of that oversight. And I mean, we understand that's federally required anyway, but it is a reassurance that we could insert here. Any other items of feedback?
Yeah, just to state a little bit on this. I mean, our intent here was we felt like we pretty much already meet this requirement and not looking to establish any additional work on anybody because we feel this is well-trodden ground.
Okay, thank you for the discussion. Okay, next is timeliness and accuracy of authorization and claims processing in accordance with Medicaid policy and contract requirements. So this is one of those things that is also in CFR and in contracts, but that CFR reference requires that Medicaid pay 90% of clean claims within 30 days and 99% of clean claims within 90 days. These standards also apply to UMIC plans, like the spelling there. So, and we have already received a note. If you see, I'll speak to the note that Becky added, but what we are seeing is that 93% of claims are being reimbursed within an average processing time of 7 days. So there is some indication that we're already meeting this, but nonetheless, we are proposing that that be the starting point for our metric. The standards, furthermore, now moving on to authorization, standard service authorizations are allowed 14 calendar days or as expeditiously as the enrollee's condition requires. In order to comply with the upcoming CMS proposed interoperability rules, our state fiscal year 2025 contracts will shorten the time frame to 7 calendar days. Pharmacy service authorizations will remain a 24-hour turnaround time. So, so that's a little bit about the department's plan for the future in line with the proposed rules. But still proposing the metrics you see before you as something that we could potentially put forward as the HB 413 working groups recommended metric for the department.
Brian, if I could just interject here, I'm thinking it might be a good idea for us to collect data similar to what we did recently, perhaps at least once a year. Maybe we collect a 3-month time frame every year. I don't know what everyone thinks about that, but
do we have any feedback from representatives here?
Becky, are you saying purely for the authorization piece?
more on the claims and the data that we just collected was specific to substance use disorder residential treatment. I'm just wondering if it might be wise for us to collect that data at least once a year. We only did a 3-month time frame recently, but maybe do another 3-month time frame at the beginning of next year, let's say.
I don't, from my perspective, I don't think there'd be any concerns with that. Would support that.
So any other feedback from the provider community and those other folks on the call? I mean, we really want to hear from you guys.
Yeah, I guess I would add something in there about that prior authorizations are no more frequent or stringent than what state Medicaid prescribes. My worry would be if there's a move toward looking more like commercial plans, that we be doing authorizations. So we do authorizations on the commercial side sometimes every 3 days, and that's just not an option for us. So I would add that.
Thank you for that recommendation, Adam. Any others? Right, then we can move to number 3, and this is more of a discussion point because as it's currently stated, it's not specifically a metric, but to again move forward the discussion, the requirement is that we have a metric for reimbursement by MCOs in the state to provide and to maintain adequacy of access to care. So we speak, as many of you know, for critical behavioral health services, we have an established essential provider fee schedule, which applies to UMIC plans. In addition, the department will be pursuing a quality pool similar to what was done with legacy ACO to incentivize our UMIC plans to maintain adequacy of access to care. So again, it's not a stated as a metric, but we wanted to put this forward as an idea to hear the work group's feedback on a metric. Emma, go ahead.
Yeah, so this is news to the plans about the quality pool, and so that I think that warrants further discussion because that also impacts the discussion around the risk corridor and all those things that we don't need to go into here. But the other thing is we also have these looming managed care regulations that are going to presumably redefine access to care. And so I just want to make sure we're not putting the cart before the horse, because I could see us spending a lot of time trying to define some of these things and then have CMS come along and say, no, we really mean something else. But then even more importantly, at the end of the day, I don't think that just trying to fit a square peg in a round hole is going to help anybody. At the end of the day, it really boils down to, is there sufficient appropriation to support these services? And so, you know, maybe we are at the point where we should be considering doing something and presenting this to, you know, legislative decision makers, similar to what's been occurring in the HCBS area, mainly because of CMS pressure. But I don't know that anyone's done a survey recently, and maybe that's something that also substance use and mental health can help with, to do a survey of providers to really determine what their costs are to provide these services in the current environment. Because I really do feel like if we just keep saying it, if we just keep saying access to care, we're going to get there. And it's like, that's nice. We all have good intentions, but really maybe what we need to do is really determine what the need is and then present that to legislative decision makers and say, look, if we're all concerned about access to care, we can't automatically create, more providers out of thin air, but this is what it's really going to take. And I don't know what the providers think about that, but yeah, I just have some concerns about making sure we're doing something meaningful and not putting the cart before the horse, I guess.
Yep. So I'll comment 2 things to that. Number 1, it is also on our list of items to evaluate provider payments and rates, not payments, but the rates, and have those assessed. You know that we are currently undertaking with Myers and Stauffer a broad study around, that's a broad rate study. But certainly it's also an item for us for consideration with regard to, for the legislative consideration this year as we're working on our budget requests, and certainly provider rates are on that list, right? As they affect access to care, certainly. We're also, as we look at what access to care looks like and knowing what CMS has drafted, I'll say first and foremost that we intend to provide feedback on that from our perspective, because it may not be realistic. It might be like a nice vision of what would be great for people, but the reality of that might not be feasible for our providers. And so we want to represent that properly up to our federal partners. But with regard to this, I think, Emma, this was very much this is not, we probably should take out the word will be, because this is a proposal and this is draft. Things are not done just, we work on these things together. So this is a draft proposal that we would pursue something like this. Okay.
Yep. And to answer your other question, Emma, I mean, it's been my understanding since the inception that oh my gosh, I just lost my entire train of thought.
The risk corridor will go.
Yes, the risk corridor will be going away.
I agree. I just think we haven't really talked about timing and
Sure.
what would take its place. And so, I mean, it's fine as a proposal. I'm just saying that even that, at the end of the day, I don't know that it's going to address true access to care. And I agree with you. What the feds are proposing is, again, they're in the ether somewhere in terms of their understanding of reality. But yeah, just need to make sure we don't get ahead of ourselves on some of this.
No, most definitely. And like Jen said, this is our first stab at it. It's nothing more than hey, this is kind of the direction we want to go, want to get your feedback. And that's exactly what the purpose of this meeting is.
I have a few comments. So if that's okay. So first, Emma, I think your idea of finding out how much it actually costs us to deliver the services is a really wonderful idea, and it would be nice to be reimbursed for the entirety rather than us having to piecemeal and hustle to try and get funds to cover all that's required to provide quality care. I do have a question about just what is the quality pool? Can you, and I mean, I'm making an assumption that that's an essential provider list and they maybe get a enhanced payment. Is that what it is? Or could you explain that?
So basically the idea behind a quality pool is we would establish specific metrics that the plan has to meet in order to receive those funds. It's that simple. So we are doing it this year in the ACO legacy contracts, where we've established certain metrics around provider engagement, data quality, and then specific HEDIS measures. And so that's a really good way to kind of put the money in the direction of where you want the plans to go. So again, since this is in regards to access to care, we would likely put some of those metrics relating to quality tied to things that drive access to care. Does that make sense?
Yep.
So that is just a suggestion that we could do something like this to help promote access to care.
Yeah, I think that's great. The last comment that I make with regard to that item is adding a time frame with which, when rates are changed, how much time do the plans have to start reimbursing? Because sometimes it's right on time, sometimes it's a year later. So it would be nice to have like a finite time frame.
And just to follow up on what Adam's saying, I think that when Becky's collected data previously, it's kind of come from the plan side. And I think it might be good to have it come from the providers, like how much are they getting paid, as opposed to how much do the plans feel like they're paying out. And Emma and Julie might be kind of kicking me under the virtual table, but I think it would be good to hear from the providers, you know, how are those payments working, not just from the plan side. And then just to circle back, because I kind of can't help myself, I think, you know, we really kind of get the delivery system that we pay for. And so not only kind of reimbursing what it costs to deliver care, but I think that we'll find that the model will evolve in the way that we want it to if we're fully funding things, you know, and that includes more case management, more peer support, more wraparound services that are actually more cost effective, but they haven't been fully funded. And so I think it's hard for places like Odyssey House and First Step House and House of Hope to deliver them in the way that they probably would be most effectively delivered. So I think that we can really kind of evolve the model, but the payment system has to be in place to kind of validate that. So I really look forward to working on that project.
Amen, Nelson.
All right, thank you. I think we can move, and actually there's some crossover into what you were just talking about, Nelson, about availability of care management services to meet the needs of Medicaid eligible individuals enrolled in the plans of MCOs in the state. So what our proposed metric, this is broken up into a couple pieces here, but our proposed metric is that each managed care organization will provide a policy outlining how individuals are identified for case or care management services, including the screening tool used, and who will provide the service. And a couple examples of who may be providing that service. So that is a proposed metric. Just to let you know some further plans that the department has, the department will, the proposals to have in place is that the department will establish a ratio of case managers to TAM members in the state fiscal year 2025 contracts. In addition, the UMICs will need to establish a process with the PMHPs regarding care coordination of their enrollees. Included in our quality pool will be required care management activities regarding primary care access, preventive care, and behavioral health care. Russ, go ahead.
Thanks, Brian. Yeah, I mean, we have processes set up today with PMHPs regarding care coordination, but tell me more about what the department's view is of that and what the definition is from your standpoint.
I can share just a bit more, and we're reflecting from what was shared with our conversations in these meetings, Russ, around the intensity of service and perhaps need for face-to-face at times, which is why we highlighted high-touch case management. And we think we've been talking about that for several months, but certainly it seems to be more of an essential need for this patient population is more intensive case management services and care coordination activities that might even extend beyond some of the typical services, and the providers should really speak to these items, but we're trying to support what we heard in our working group with regard to the needs of this population. So Adam, if you want to speak up, that's what we're trying to support with this, Russ.
Well,
and
maybe
why from the start, like that intensive case management code, so you could be billing at like a different rate for intensive case management versus traditional case management services.
yeah, well, maybe one more clarification. So currently TAM is not in the prepaid mental health plans, right? And so we're talking about PMHPs. And so when you say establishing a process with PMHPs around intensity of managing this population is not in PMHP. So I guess that's the part I'm trying to tease out what this means.
This
Uh,
would be,
who-
go for it. Go ahead.
I mean, I think there's multiple pieces here, and I mean, we're open to feedback of how to break these out. So the metrics to establish as part of this working group are irrespective of TAM being in plans, whether it's PMHPs or UMIC. So we have to establish metrics in the get-go. But I think that's, and then we're further talking about future plans and proposals. And so like we're talking about both current tense and future tense, I guess. Metrics today and also plans for tomorrow.
Okay, well, I
yeah.
think, I mean, you can tease that out more in terms of what you really mean, or help us understand more what you mean by PMHP. I think what you mean is really working with the providers.
The essential providers, basically,
right.
mostly, yes.
Yes, that's exactly what we meant, and I apologize. Jen and I were working on this last night. Our intent there was to say we want the UMIC plans to be working with whoever is providing that service on the ground and coordinate that care that way.
Got it.
Yes, that
Okay.
was our intent. Thank you for the discussion and clarity.
Adam, I think you were next.
Sure. Well, I think I was going to state it. The PMHP should be essential providers there, but I guess I like the requirement of figuring out if you have a care manager at one of the ACOs and how they are coordinating with case management if we're serving the client here, and who does what and when, and what responsibilities are there, and what it can be, getting a birth certificate or helping them with court, all of that kind of stuff. So there's a lot of stuff that's going on. So it'd be really nice to have, this is what we expect you to do. This is what we expect us to do.
And along those lines, that's what I wanted to comment on too. I mean, we've had this discussion before about how a lot of case management actually occurs already at the essential provider level. And I think before we start establishing metrics, we need to be very clear about care management versus case management, and where the case management is being handed off to the essential provider. Great. How do we account for that and document that, so we don't have others that are not necessarily connected to an essential provider? We don't have them slipping through the cracks too. So, I mean, there's a lot more detail behind the scenes that I think we need to spell out before we start establishing even what the baseline is, before we determine what a metric is. And just coming up with so many people per so many TAM members doesn't mean anything really until we start driving out some of these specifics, so we know who's responsible for what, and those types of things. So again, just don't want to put the cart before the horse here.
And if I'm capturing something correctly, help me just correct my notes. I'm happy for my editing or what I'm writing isn't capturing what you're saying. Just flag me so I can modify it. But thank you for those comments.
Yes, thank you. Becky, I think you were next.
So one thought that I'm having is I'm wondering if it might be useful for us to involve someone from our HRSS team to this meeting. You know, I don't know if that would be useful or not, just to make sure we're involving them in the housing piece, as well as ensuring that the plans, you know, are doing good coordination with housing authorities as well. That gets a little complicated when you're dealing with people who have felony charges. Housing assistance is not always available through the housing authorities, but maybe that's something we may just want to keep in mind, is how do we make sure we're involving housing in these discussions?
And I think that would be helpful. Yes, but we need to get to the basics first. And then
Sure.
I definitely think we need to have them involved in the discussion for sure.
Yeah. Okay. Thank you, Lisa. Lisa, if you're speaking, you're on mute.
Can you hear me now?
Yeah.
I guess I can put my hand down. I just really wanted to underline what Adam and what Emma said was really my remark, is just case management is such a intensive, interwoven part of what we've done for decades, and really defining the differences. And I think I think we all think we know what we mean, but it's quite a different animal, and how to connect that so that there aren't overlaps and it doesn't create a layer of chaos. But otherwise, I just totally underline what Adam and Emma just said.
Great. Thank you. Russ, go ahead.
Yeah, I mean, I guess just building on that, I mean, it would be helpful to understand, you know, in the current fee-for-service model, how that case management, care management is happening today and is reimbursed, and you know what's intended to be covered, so we can understand what the gap is between what's actually covered today, and if there is a gap between what should be covered in a more intensive, or in a justice involved more intensive view.
So Russ, I'm going to take a stab at that one. I think that's one of the primary purposes of why this work group was formed, because in the fee-for-service model, it is not happening. And so that is one of the main considerations, is why should this move into managed care? It's so they can get these case management services.
Yeah, and I think to your point, Adam, Eric, that it's not like members don't get care or case management. It's just not organized at the department level. You know, again, that type of service is managed at the provider level in most cases.
I would just add, we're doing it, we're just not being reimbursed for it. So we need to do it to have success with the clients, but it would be nice to have this be reimbursable and really have a focus on that. But also to everybody's points, we need to be talking the same language, because I think sometimes when we're talking about case management with ACOs, they may have a different viewpoint of like, okay, we're going to help them get to a provider appointment or something like that, where we're like talking about connecting them with vocational training or a school, or like it's very, very broad. So it would be helpful to make sure that we're talking all about the same thing, and also what the needs are of the people that we're serving, so that we don't omit something.
It will be very different for people that are not attached to the essential providers too. But you know, for people that are attached to the essential providers, I feel like the best thing we can do is to pay good case management rates so that they can build up their case management system. It's going to be more effective when it's closer to treatment. And that's really kind of their core competency. So I think the plans are going to have a lot of care management, moving into case management responsibilities under TAM. But a lot of what I'd like to see too is to be able to reward and partner with providers to really to do a lot of that work as well. You know, especially when we're talking about housing and nutrition assistance, you know, that's kind of on the ground stuff. And I think that it's going to be best delivered through the providers if we can do that. So, I mean, this is a lot of work we're talking about. And it's kind of overwhelming to think about, but I think that we can build a good system and that there's kind of a good infrastructure in place already to build out. But I don't think we can just like fill up the plans with enough capacity to do it on our own. I think we really need to use the existing providers that are in the network.
Yeah, very good point. I just looked at the time and I was kind of blown away. We are 3 minutes to the end point. So Jen, I don't know if you would like me to continue or should we hold something hold this and maybe do it by email? What would you prefer?
Yeah. Well, actually, we got further than I thought. Our intent today was, depending on how robust the discussion was, to actually cover 1 or 2 of these items and know that we have time to have further discussions. But in the context of laying out what our timeline is with regard to some of the discussions that we have with justice involved work around some of the integrated models, we wanted to align these conversations with that as well. So I think, Brian, we can pause. Next time we meet, we can pick up from here, and we can send out some nice meeting minutes from what was discussed today as well. And then we'll augment with that next time.
Great,
Oh,
thanks.
go ahead, Emma.
So Jen and others, I guess the question I have is, you know, at some point we talked about if a change was going to be made, clearly it's not going to happen by July 1 of this year. So we talked July 1 of next year, possibly, if that even happens. But if that were to be the decision, I'm not sure, although I'm not a big fan of having more meetings, I'm not sure doing this quarterly, you know, especially between now and the session, if that's going to be sufficient. So I'll just put that out there because there is a lot of work to be done. And I think these meetings are great, but having an hour meeting, presenting something, not having the opportunity to have more like just, you know, boots on the ground input to really flesh it out and develop it. I just feel like we probably either need to have some subcommittees or meet more often. I don't know what the rest of the group thinks, or we'll be doing this for the next 5 years, you know, to be quite frank. So.
To others, I mean, we certainly can increase the cadence of our meetings. I think I'd mentioned, you know, we're going to be engaging in discussions around integrated models in other settings. So I think some of this work will be done with a broader group of individuals outside of this HB 413 work group. But we can certainly increase the cadence of this meeting as well.
Well, it's just a suggestion, so you guys can take it back and think about it. And,
sure.
You know.
Okay, with that, thank you. The hour did go by very quickly. We're really glad we could go through these pieces with you today and actually got into some really good discussion points. So we look forward to our next meeting. Thank you, everyone. Have a nice weekend.
Thank you.
Thank you.
Thanks. Bye.